Hello, and welcome to the ASCO Daily News Podcast. I'm Monty Pal, a medical oncologist, professor and vice chair of medical oncology at the City of Hope Comprehensive Cancer Center in Los Angeles, California. Now, it's probably no surprise to this audience that immunotherapy has transformed the treatment landscape for multiple cancer types. It remains a pillar of modern oncology. Having said that, I think we've all been baffled by certain toxicities that we run into in the clinic. Today, I'm delighted to be joined by Dr. Pauline Funchain to discuss some of the checkpoint inhibitor toxicities that people struggle with most. And we'll also touch on some side effects of immunotherapy beyond checkpoint inhibitors, CAR T cells, bispecifics, so on and so forth. Dr. Funchain is a dear friend, and she's an associate professor and associate director of cancer research training and education at the Stanford Cancer Institute. She's co-director of the immunotherapy toxicity program and the skin cancer genomics program at Stanford, where she also serves as Associate Program Director of Hematology and Oncology Fellowship. Dr. Funchain is also the co-founder of Aspire, and we're going to talk about that a little bit today, the Alliance for the Support and Prevention of Immune-Related Events. FYI for listeners, if you're interested in our disclosures, they're available at the transcript of this episode. Pauline, thanks so much for joining us today.
Monty, thank you for this invitation. It's always great to talk.
So for the audience, Pauline and I know each other from my days as a fellow at City of Hope. She was a resident at Harbor UCLA and a stellar resident at that. It's just been amazing to sort of see your career grow and blossom and to witness all the cool things that you're doing. Aspire in particular sort of caught my eye. So again, for listeners, this is the Alliance for the Support and Prevention of Immune-Related Events. Can you tell us a little bit briefly about the genesis of that, how that came about?
So there was a bunch of us who are really struggling. I mean, all of us have struggled with these immune-related adverse events, these IREs. They're new disease states. And even though they look like autoimmune diseases, they tend to need a whole lot more steroid than autoimmune diseases do. And they don't totally present in the same way. And in fact, triple M or triple M overlap syndrome is a completely new IRE, a new immune state that we've never had before the advent of checkpoint inhibitor. And so a triple M, for those of you who aren't as familiar, that is the constellation of myocarditis, myositis, and myasthenia gravis, something that never occurs as a natural autoimmune disease. So we were starting to realize that there were some major differences with these IREs and autoimmune diseases. We couldn't treat them the right way. We really needed to learn more about them. And a bunch of us who had interest in this said, look, we really need to be all in one space to talk about what we're doing, because all of our treatments were our own little homegrown brews, and we needed to really get together and understand how to treat these things, how to diagnose them, and then learn more about them. So Alexa Mira from Ohio State, Carrie Reynolds from Mass Gen, we put together this research consortium, brought together all of our IRE friends, got our best subspecialists together in a research consortium, which is now only about a year and a half old. And we made this research consortium, the Alliance for Support and Prevention of Immune-Related Events. And we reached out to ASCO, and ASCO was so kind to grant us a community of practice. So we met for the first time as a community of practice at the ASCO annual meeting just this past June, and really got an ASCO community together to really think about how to, again, diagnose, prevent, treat IREs.
This is interesting to me. The ASCO community of practice phenomenon is something that I wasn't super familiar with. Can you explain to our listenership, what is the ASCO community of practice model? If you have particular interests, how do you sort of get one started?
Yeah, so ASCO has an entire page on their community of practice. There are multiple community of practice groups or COPs. There are ones for supportive oncology and survivorship. There's women in oncology. There's a group for international medical graduates. And there's about, I think, 10 or 12 now of these that have a physical presence at ASCO, but also a virtual presence on the ASCO community of practice site. So if you were interested in any one of these, and you can see them on the ASCO communities of practice sites, you would ask to become a member. Once granted membership, then there's a whole web page of postings and conversations that people can have. You can get email digests of conversations that happen on the website, and then you can anchor it with in-person participation at the annual meeting.
That's awesome. And I can think of so many different, foci within oncology that really sort of deserve a community of practice, this definitely being one of them. It strikes me as being so interesting. I mean, the checkpoint inhibitors have been around for a while now. I think when you and I were in training, gosh, back then, these were just a little bit of a pipe dream, right? But having said that, I would probably say that more than half of my kidney cancer practice is either on checkpoint inhibitors, and the vast majority have been on one at some point in their past, right? With that in mind, we've all treated a lot of patients with these drugs. Why is it that we still struggle to manage the toxicities? And just to take that one step further, what are some of the toxicities that perhaps through Aspire or through your experience people struggle with the most?
So I think we are still struggling with these because, again, they're new disease states, right? This is what we all experienced with COVID, a brand new virus and a brand new syndrome. We now have 20 plus of these as IREs. And what we've realized about them is that immune activation that happens with these is so much more than what we've seen with autoimmune diseases. So, for instance, if you have a Crohn's or ulcerative colitis, you'll top out at 40 to 60 milligrams of prednisone if a Crohn's flare or ulcerative colitis flare happens. But for our severe IR colitises, it's at least 1 mg per kg, often goes up to 2 mg per kg. We, in some cases, have done 1 gram pulses if we're worried that somebody's going to perforate. So that was sort of like the first 5 years of treating IRE. And then now in the sort of second 5 years of treating IRE, we've realized that that's a lot of immunosuppression. And we might be able to get away with less with the newer biologics that are on board. So we're struggling to try to get the data for some of these IREs that we've known for a while, but to try to get newer treatments that may immunosuppress less so that you may still be able to retain that tumor response. And in fact, some of the preclinical studies suggest that some of these biologics may actually synergize with the immunotherapy and actually make the immunotherapy more effective from a tumor perspective and calm down the IRE as sort of the bystander effect. So we are still trying to optimize those. Getting up trials in this space has been very difficult. That's one of the reasons for the genesis of Aspire, because we realized we needed to band together to have a bigger voice in that realm. Then there are other things that are brand new. So we talked about triple M. So triple M, again, with triple M or any myocarditis or myasthenia, there is about a 50% chance of death from IRAE based on the literature. I think we're getting better at recognizing this. And so at Stanford, we have some data to say that if you serially follow troponin, that maybe your outcomes are better. You can potentially lower the percentage of cases that are fatal because you can catch them early. This is all preliminary data, but again, these are all things that are evolving and we don't all have the right answer. Even the serial troponin thing, I think, is pretty controversial. And in fact, at one of our quarterly Zoom meetings that we are doing in Aspire in December is going to sort of flesh out that controversy about serial troponin measuring and what's the best thing to use. Would you use something like abatacept or would you use ruxolitinib? Which one is better? I think there's a lot of controversy still about these things.
You've really piqued my curiosity here because you think about the cons of treating IRAEs, right? And I worry exactly about what you'd mentioned, right? Which is, gosh, what's going on with this tumor in terms of immunosuppression? But you think about some of the newer agents. You mentioned ruxolitinib. I've heard of dasatinib, for instance, in this setting. Frankly speaking, a lot of these, as you point out, are really thought of as being also anti-cancer drugs. So you've really got me thinking about the potential synergy between perhaps suppressing an RAE and augmenting anti-tumor activity, which I think is very interesting. Am I on the right track with that?
I think so, but you'll find that a lot of people will not even go there because they're worried about how much immunosuppression you're going to cause. I'm at heart a geneticist, but I think an immunologist will happily tell you that the immune system is very complex. There are multiple pathways, and these drugs don't all target the same immune pathways. So if we understand a little bit more about the pathways we're targeting and pick apart the pathways that are really, really tumor relevant and other pathways that are not tumor relevant, you may be able to piece together a better marriage of tumor response and IRE control.
Well, kind of on this topic, and again, leaning on your background in genetics, where are we in terms of predicting these IRAEs? You'd think the holy grail would be picking out a SNP or something of this sort, right? That could potentially identify that patient who's going to get triple M or, at the very least, a significant high-grade IRAE event. Are we anywhere closer to that in 2025?
There have been data published. There have been some big GWAS studies. All of the effect sizes are pretty small. So there are some prediction algorithms, but none of them are clinically useful. And I think when you look at the odds ratios, they'll increase risk by maybe 20%. I think one of the things that we found in a very small series and supported anecdotally is something as easy as family history of autoimmune disease is probably more predictive at this point than any of those types of markers. I think we'll get there, but we are not anywhere near where we'd like to be. Things like TMB also, actually, there's some good data about higher TMB, higher risk of IRE too.
Interesting, because I see all this data coming through IL-8 polymorphisms, et cetera. And I just wondered if any of that was ready for prime time. But I mean, this is a good message for the practicing clinician. Sounds like we're not quite there yet. And I could probably keep you on for another entire podcast to talk about this topic, but let's see if we can at least skim the surface. I never thought I'd see the day when BiTEs and CAR-Ts were entering into my kidney cancer practice, but in fact, it's really become central to a lot of our clinical trials in RCC these days. I would be lying if I didn't say that I wasn't struggling with the toxicities and so forth associated with these drugs. Can you give us a quick primer, maybe just good resources that people can go to for managing toxicity with BiTEs and with CAR and with some of these novel therapeutic modalities that we're using in the oncology clinics?
I know there's a recently published toxicity manual for BiTEs in hematologic malignancies. I think it was in blood. And CAR-T is covered in many IRE guidelines. So ASCO guidelines actually has CAR-T. And I would be remiss not to point out that actually ASCO has I'm a little biased, but a wonderful guideline on IRE that is actually being updated as we speak. We are hoping for publication next year. I find the format of that, there are many guidelines out there, actually. There's ASCO, SITC, ESMO has a guideline for IRAE, but I find the formatting of the ASCO guideline to be much easier to flip through during clinic, just because of the visual format of the tables. But that is going to be updated next year. And with CAR-T, there's now multiple publications also in terms of guidelines. But what I will say about bispecifics and CAR-T, so they have very similar toxicities in terms of the cytokine release and also with the ICANS, so the neurotoxicity. But what we've been finding that's really interesting with BiTEs and CAR-T, and actually even with TIL, cytokine release is very similar to some of the IL-2 toxicities, but not identical that we see with TIL treatment. But now we're starting to see overlap. So patients who have been treated with immunotherapy and then go on to get a bispecific or then go on to get TIL. So I've seen some colitis that have occurred after the fact. Some of the newer CAR-Ts without checkpoint have been causing some really interesting, probably not in a good way, but interesting biologically colitis that are really refractory. So we are starting to see some overlap. And again, I think this field is just evolving constantly.
Yeah, no, I almost think I need to go back to that fellowship that you and I did together 20 years ago and, and see if I could repeat some coursework on CAR-T management. Pauline, I could probably keep you on the horn for hours, but this has just been terrific. Thank you so much for sharing all of your insights with us today on the ASCO Daily News Podcast.
Thank you for the invitation. It was wonderful to talk about this, and it was wonderful to catch up a little bit, Monty.
Same here. And thanks to our listeners, too. If you value the insights you heard today on the ASCO Daily News Podcast, please rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.